So welcome everyone to the Penn State College of Medicine Understanding Primary Immunodeficiency. It's a Project ECHO Clinician Education Series. We're delighted that you're joining us today. My name is Jackie. I'm a member of the ECHO team, and I'm going to start us off with some quick announcements and introductions. If you're logged in with a name that's not identifiable, please put your name and your email address into the chat for our record-keeping purposes. If anyone's joining with you, please include their names as well. We ask that you stay muted unless you're speaking, but of course, feel free to unmute or use the chat at any point throughout the session to communicate. Please remember that when we're discussing cases, no personally identifiable information is allowed. We are recording these sessions for educational and quality improvement purposes, and we share all materials after each session. In the spirit of Project ECHO's all teach, all learn approach, we're always on a first name basis during the session. So today we're going to be starting with a brief talk on treatment options by Dr. Joud Hajjar, and that will be followed by a case discussion also coming from Dr. Hajjar. During the presentation and case, again, feel free to put your questions into the chat. We have a team of specialists online. I'm going to ask them to introduce themselves shortly. They'll help to field questions, but remember, this is all teach, all learn, so everyone can share questions and answers. And also, you don't need to rely on chat. As a matter of fact, if you unmute and ask your questions or provide your feedback, it makes it a little easier for all of us to manage the chat, which does get a little chaotic at some point because you have wonderful feedback. So let me ask our hub team to introduce themselves, and then we'll go ahead and get started. Let's start with Colleen.
Hello, everyone. My name is Colleen Brock. I'm the manager of medical programs at IDF. I am a registered nurse, a parent to 2 young adult children with PI, and I also have a PI. And so thank you for being here today.
Thank you. Megan.
Hey everyone, my name is Megan Messick, and I'm the Director of Education at the Immune Deficiency Foundation. And to echo Colleen's sentiments, we're so excited to be on today for this exciting presentation.
Thank you. Ken.
Good morning, my name is Ken Bass, and I'm a patient with primary immune deficiency. I also work as a support group leader in Texas for others who are patients with PI.
Thank you. Diana.
My name is Diana, and I am the mother of a child with PI who is 10.
Thank you. Paula.
Hi, I'm Paula now. I'm a physician taking care of patients with immunodeficiencies.
Thank you. I didn't mention 2 of my ECHO colleagues are online with me, Laura and Caitlin. So if you have any technical issues or questions, feel free to reach out to either of them or myself throughout. And Jude, I'm just going to hand things over to you. You can introduce yourself and get us started.
Thank you so much. Well, good morning or good afternoon, everybody, depending on where you are. My name is Joud Hajjar. I'm a clinical immunologist and allergist at Baylor College of Medicine in Houston, Texas. And I'm really excited to share some of the work that we are doing, taking care of patients with immunodeficiency, and kind of talk to you specifically about the management in patients with primary immunodeficiency disorders. Here are my disclosures. There is no conflict of interest between anything I'm going to present today and my disclosures. And I was specifically requested to talk about treatment options for patients with primary immunodeficiency disorders that I'm going to refer to as PI for short. And when I tried to put in some objectives for this presentation, I thought it's better to have like an iBird view on the management for all PIs, because it's really not possible to cover everything in a short talk. So my goals from this presentation are to first explain the current management strategies for patients with PI, including preventative measurements, replacement modulation therapy, as well as curative options, and highlight the importance of multidisciplinary approach and close follow-up in patients with PI, and provide information on specific treatment options and referral criteria for PI patients, and improve collaborations between the primary providers and the specialist. I really tried to here take the view of a provider who's not an immunologist, who's taking care of patients with a PI, and wanted to kind of know, what should I know about those patients? If they are on treatments, what I should know about those treatments. If they are in trouble, what should I do? And this is very interactive, so feel free to stop me or put questions in the chat, and I'll try to answer those as much as I can. So I know that you've heard about the presentations of patients with PI before, but it's important to just refresh everybody's memory about how those patients present, because the management in patients with PI, for the most part, is directed to the specific presentations of each patient. So you may recall that patients with PI, for the most part, present with recurrent infections. But it's very important to remember that although recurrent infections are the most common presentation, it's not the only one. So those patients could present with autoimmunity as well as autoinflammation. And sometimes those presentations happen together. So for example, you could have a patient who's coming with recurrent fevers and they have a diagnosis of PI, and you've exhausted all your evaluations and you cannot find the pathogen. And of course, you're going to try to treat those for potential infections. But keep in mind that sometimes autoimmunity and autoinflammation could mimic infection. And it's important to keep this in the back of your mind as you work your patients, to think about autoimmunity and autoinflammation in order for you to treat it appropriately. Malignancy is another big presentation that some of us don't think about it very much, particularly in children. But a lot of our patients with PI are at increased risk of malignancy, either because their disease predisposed them directly, or the medications that they have received, or the therapeutics, for example, like hematopoietic stem cell transplant, and some of the medications that they have received in conditioning. So it's very, very important to understand how those patients could present, and that some of the presentations can happen together in order for us to make the proper diagnosis and then the management. Important considerations. You know, when I'm asked to talk about the management of PI, it's like telling a cardiologist talk about the management of all heart disease, or for a psychiatrist to say, talk about the management of all mental illnesses. So it's very important to know that there are personalized medicine approaches for patients with PI, obviously based on the specific diagnosis, also based on the specific genetic defect that we know in some of the cases, and oftentimes is also directed towards the organs that have been involved in the specific patient's disease. So no two patients would have the exact same treatment plan. And because PI can involve multiple organs, you're going to see often that those patients see multiple specialists, and each one of the specialists will have to manage their organ under the big umbrella of understanding that this is in the context of underlying primary immunodeficiency. The therapeutics are in patients with rare disorders, primary PI, coming from small clinical studies. Rarely you will find in the literature double-blind placebo-controlled study on thousands of patients of PI. So we have to keep in mind that our therapeutics are approved based on small sample size. A lot of the time what we use is based on a level of evidence coming from case series or even expert opinion. Of course, we try to personalize the treatments as much as we can, but because we don't have data that come in from large number of patients like what you see in cancer or heart disease, it's very important as you treat your patient to follow them up very closely, to look for a response. If they are not responding, you have to see, am I treating the right diagnosis? Am I treating the underlying disease? Is there anything else going on? Why am I not seeing the response? And continue to follow them very closely. So it's not like, okay, I'll start the medicine, I'll see you in 6 months. Oftentimes those patients require close follow-up, require that we get a sense whether they are not responding or not, and adjust our therapeutics based on their specific response. So now we kind of have a general understanding of the management of PI. Let's zoom in on specific goals that as clinical immunologists we have when we manage patients with PI. And I like to think about it as kind of three large categories, although they intertwine quite a bit. But there is one goal for prevention / prophylaxis, which means that, as I mentioned earlier, most of the patients present with recurrent infections. So there are interventions that we can do to prevent them from having infections. Less commonly, but possibly that we can prevent them from having autoimmunity and autoinflammation, or at least get it under control, which is in replacement modulation. And we sometimes do aim to cure the primary immunodeficiency disorder. Unfortunately, now this goal is more achievable. Of course, with the newborn screening, we can pick up children with severe combined immunodeficiency at birth, and we can give them hematopoietic stem cell transplant early on, and that can be considered for the most part as a cure. But I'll mention that, cure is a relative term, and we always have to make a long-term follow-up for those patients, even if they are technically cured for the short term. So in prophylaxis, perhaps the word that comes into mind when we talk about prophylaxis, especially after the COVID pandemic, is the term for vaccines, right? Because vaccines are perhaps the most acceptable method of prevention in humanity after hand washing for prevention from multiple infections. And we definitely used vaccines quite a bit in the PI world to prevent from infections. Now, in PI patients, there are several considerations that we have to keep in mind when we think about vaccines. First, not all the patients with PI will respond to vaccines. So there are patients who have defects in their B cell compartment, which is the compartment that is responsible for making antibodies. So if you're giving vaccine, for example, against tetanus, diphtheria, or pneumonia, then those patients will not be able to generate antibodies that will neutralize those bacteria. So those vaccines will not work. More importantly is that there are some vaccines that could be harmful for patients with PI. For example, live viral vaccines and attenuated bacterial vaccines. For patients with severe T cell defects, giving them live viral vaccine like the varicella vaccine or the MMR could potentially be harmful because it could actually give them the infection. Another example for the attenuated bacterial vaccine is the BCG, which is not very commonly used in the US, but it's definitely used in multiple developing countries. And it is important in preventing like the multi-spread TB, but in certain patients with primary immunodeficiency disorders, BCG could give major problems, BCGiosis. And those patients could be the patients with T cell defects, could be patients with neutrophil defects, such as chronic granulomatous disease. So it's very important to kind of have a little understanding about the underlying defect of your PI patients and be aware of some of the contraindications in the world of vaccine. But the flip side to that we can use the vaccines as tools to prevent. For example, we have patients, they are rare, but definitely there, with terminal complement defects. And those patients will not be able to generate protection against specific pathogens like the Neisseria meningitis. And the treatment for those patients, for the most part, is to give them hypervaccination for those specific meningitis types and also antibiotics. So vaccines can be very, very helpful. We have some patients who are unable to respond to sugar-based vaccines against pneumonia, but they do a decent job against the conjugated protein vaccine. So we can use this as a tool for prevention as well. The second line of prophylaxis is prophylactic antimicrobials, obviously antibiotics, but sometimes also antifungal and antiviral. And those are geared towards the specific pathogens that our patients are more prone to have infections with. So for example, patients with major T cell defects are prone to have bacterial infections, viral and fungal. So they will end up receiving all those prophylaxis, antibiotics, antiviral, and antifungal. But there are other diseases in which the immune defect spectrum is a little bit narrower. For example, patients with antibody deficiency tend to have much more tendency to develop sinopulmonary infection with encapsulated bacteria like Streptococcus pneumonia or Haemophilus influenza. And for those patients, having specific antibiotics that could prevent or those specific infections would be appropriate rather than using very wide spectrum antibiotics. And there are patients who are only prone to have fungal infections like chronic mucocutaneous candidiasis, and some of those patients will go on limited scope antifungal. Of course, every time we use a prophylactic antibiotics, we would have lost this antibiotic as a treatment option. There is an impact of long-term prophylactic antibiotics on the gut microbiome and bacterial resistance as well. So we don't take those antibiotics lightly, but sometimes they do make huge differences and they are important. Finally, there are specific PIs that are prone to have specific pathogens, either because of the defect or the complications. And I put in here some examples, but perhaps I'll just use the bronchiectasis. So patients who develop recurrent pneumonias could end up having bronchiectasis. And similar to cystic fibrosis, once you have bronchiectasis, then this defect will increase the risk for specific pathogens like methicillin-resistant Staph aureus, MRSA, as well as Pseudomonas. So when we have patients with bronchiectasis, we often work with the pulmonologist to make sure that those patients are on prophylactic regimen. This sometimes could be by nebulizer when we give them specific nebulized antibiotics that could prevent against MRSA and Pseudomonas, and sometimes by oral antibiotics. So kind of recap, we use vaccines and antimicrobials as preventative measures to try to prevent infections from happening. The second goal of our treatment is replacement. So when we think about the immune system, you're thinking about an army that is supposed to defend the body against multiple infections. And when a patient have PI, they sometimes have gaps in those armies on some front lines. And if possible, replacing those gaps could potentially be very effective and sometimes even seamless. We don't have products that 100% replace the defect, but immunoglobulin replacement therapy, IgG products, are perhaps the most important tools that a clinical immunologist have in their toolbox, and they are very helpful, and we lean on them quite a bit in managing patients with variable and very different PI diagnoses. Immunoglobulin replacement therapies, and I thought it's important to kind of provide a few lines about them, are human products. They are collected by blood donations from healthy individuals who are regular donors to the industry. They are screened against all the blood-borne pathogens, and they are usually regular donors who are healthy and vaccinated. If you think about it, each batch of immunoglobulin is donated from several thousands of healthy individuals to be able to provide a wide experience of those immunoglobulins against multiple pathogens. And immunoglobulin replacement therapy can be given either through the IV, typically once a month, or under the skin subcutaneously, which can be in a wide variety of schedules from once a week to every other week to sometimes once a month in specific products. The immunoglobulins contain only IgG. So we are not able to replace IgA and IgM at this time. So it's only IgG. But IgG is the biggest umbrella of immunoglobulins, and it carries some redundancy with the function of IgA and IgM. So it can help our patients fight infections. And there are multiple studies that have shown that immunoglobulin replacement therapy protect against bacterial infections, cytopulmonary pneumonias, otitis media, etc. High-dose immunoglobulins as well can be used as immunomodulatory agents. And in general, when they are prescribed correctly with the correct dose and for the right indications, they are often well tolerated. They do have some side effects that are local, especially if you're injecting sub-Q, or systematic, similar to what happens when you get a blood product if you're giving IV. But for the most part, clinical immunologists have learned to provide some tips and tricks to make those products more tolerated for the long term. And if a patient has an underlying immunodeficiency that is incurable, that includes low immunoglobulins or hypogammaglobulinemia, oftentimes those patients will end up on those products for life. But they are very helpful. So if I am a physician who's not a clinical immunologist who spend a lot of time taking care of patients on immunoglobulins, what should I ask my patients if they come and say, I have a PI and I am on immunoglobulins? Perhaps the most important questions are you taking this product and are you taking it regularly? Are you missing doses? Are you experiencing side effects that are preventing you from taking the medicine? Because that will be the fork in the road. Is my patient having problems with infections, autoimmunity, while they are actually taking their immunoglobulins in the right way, or because they are not taking it? And as well, we have to know whether the immunoglobulins are in the appropriate dose. So we can ask, what was the last IgG level that was measured? Because we do measure IgG levels in those patients. And we try to do it as a trough, which means at the lowest point before the next infusion. And kind of in general terms, we try to keep it close to 1000 milligram per deciliter, which is kind of a hard set number, but each patient will have their physiological trough. But in general, if you have a patient who's having a lot of infections and their IgG is like 300, 400, 500, then you would say that perhaps they should follow up with their clinical immunologist, and perhaps this is contributing to their recurrent infections. Immune modulation is important, and it's kind of a moving target right now for clinical immunologists. So I mentioned autoimmunity and autoinflammation. And although we worry a lot about infections in patients with PI, autoimmunity and autoinflammation could be even more dangerous, causing in-organ damage to our patients that are harder to treat. So for some of those patients who have autoimmunity and autoinflammation, we do have to suppress their immune system that is now not only being weak, but is being dysregulated, that is starting to attack the body. There are a wide variety of immune suppression medications that can be used. Some of them are broad spectrum and not very specific, like steroids or anti-TNF medications, methotrexate, mycophenolate, cyclophosphamide, you really name it. Most of the immune suppression has been used one way or another in patients with PI. But there are now more targeted therapeutics that we perhaps borrowed from other diseases like rheumatology or GI for inflammatory bowel disease. But now, with the understanding of the specific genetic defects that some of the patients have, we can choose targeted therapeutics. For example, if you have a patient with CTLA haploinsufficiency, there is a product that actually is a CTLA 4. And this is a medicine that has been there for years in the world of rheumatology that we can use. Now, even more, there are patients who have a gain of function mutation in STAT, for example, and there are medications in the world of hematology that target the pathway specifically. So we can borrow those medications and use them to have a targeted therapy in which most of the pressure is being put on the target that is hyperactive without a lot of collateral damage, if you will. So it's a concept that sometimes is scary to try to suppress patients who are immunocompromised, but sometimes it's really an important concept in protecting and preventing further damage and organ damage. So if my patient with PI is taking immune suppressants, what should I think about? And I would say, ask your patients why you're taking this medication. And if you don't get a good answer, reach to the clinical immunologist and understand, because every now and then you have a patient who was started on something and was carried on. And it's very important to always ask ourselves, why is this patient on immune suppression? Is it working or is it not working? If it's not working or the disease in remission, can we take it out? So it's very important. And then perhaps we need to familiarize ourselves with some of the side effects and particularly the expected infections that could occur when patients are on specific immune suppression. Our colleagues in GI and rheumatology and oncology, they usually have even a list of things that they screen their patients for before they start on specific biologics. So you might have heard of somebody with arthritis, they get the TB screening, they get certain kind of blood work and hepatitis panel before they start on specific biologics, because there is potentially a risk of reactivating some of those infections. As clinical immunologists, we remind our colleagues that any test that is reliable on antibodies may not be a good test. For example, we tell our patients, we tell our providers, don't screen for HIV antibody if your patient cannot make antibody. And similarly, do not look for hepatitis antibodies if your patient cannot make antibodies, but do PCR studies that are helpful, or use other technologies that are not antibody dependent in order for you to look for those infections before you start the medications. And while my patient is on medications, it's important to understand whether this medicine suppresses the T cells or the B cells, and what kind of anticipated infections that my patients can have. What are the side effects? Mouth ulcers, alopecia, anything that you can think of. And then what are the labs that I can check? And here I would say that it's hard to kind of keep a long list in your head, especially with a world in which biologics are being approved repeatedly. So using resources up to date even oftentimes provides you a list of anticipated infections in labs that you can check towards the end of the medication information, and reaching out to colleagues as well is very important. I'll end by discussing the curative approaches very superficially. And I mentioned already that severe combined immunodeficiency is considered now a disease with major impact from newborn screening. Hematopoietic stem cell transplant could prevent curative and save life very early for those children who are oftentimes considered to be having a fatal disease before the age of 1 if they have not been transplanted. I am an internist by training before I became a clinical immunologist and allergist. So I would say that I would put the cure between quotations, because we are now seeing those individuals getting older, and we have to make sure that we continue to follow them for some of the side effects that were not noted before. So although we say cure, I would say that maintaining a good lifestyle, but definitely requiring a certain level of follow-up over all years of life. The other example that could potentially be curative is thymus transplant. That has recently been FDA approved measure for selected patients with DiGeorge syndrome. Not every DiGeorge patient will require thymus transplant, but those patients who have complete absence of the thymus tissue with very severe T cell defects could benefit from a thymus transplant, which could be curative. And finally, the emerging gene therapy strategies that now becoming FDA approved as well could change the landscape. And perhaps in the future, a talk like this will not say anything like I mentioned earlier, and gene therapeutics and maybe even during the conception period will be the way to go. And I really hope that we'll see much more of this later on. But for now, we still, in the era in which we are putting a lot of band-aids, we're doing a lot of supportive management for our patients with PI. So it continues to be very important to early recognize our patients with PI when they are having symptoms that are not responding. It's very important to collaborate with multiple subspecialists, especially if you have a patient with multiple organ involvement. There are malignancies that I did not touch upon much, but they are important to think about, to screen for. And it's oftentimes a multidisciplinary approach is needed, as I mentioned, and close follow-up and monitoring. If your patient is not responding, go back, check with other providers, adjust their therapy as needed. I put in some references here. The first is an immunodeficiency search.com. It's really nice. And you can go to the website and enter either pathogen, and it can give you differential of certain PIs that could present with the recurrent infections, or you could put a name of a PI and can give you kind of few liners about the presentation, the lab abnormalities, and some references about the disease. Some of them are a little bit outdated, but overall, it's really a good resource. The Clinical Immunology Society has put in together the web book with all the biologics that are currently FDA approved. And I think this is a very useful resource to look at if your patient is on a biologic, and some of them, you don't know what even they are for. So they put in the target and their mechanism of action and what they are FDA approved, knowing that for a lot of our patients, we're using off-label. And up to date, I really like it because it does have a lot of information about medications, their mechanism in action, very briefly, what to look for and the side effect. So in your busy clinic, I think it's a very reasonable resource to use. And with that, I will stop here and let Jackie tell me whether I take questions now or move to the case. I'm gonna end the show because I have the case on another slide.
All right. Well, let's see. If anybody has any questions about our flash talk, feel free to unmute and ask those questions or put them into the chat. We'll wait a minute or so. And if not, then we'll move on to our case discussion.
I'll just start sharing the case
Okay,
discussion
perfect.
slide just to kind of make sure we have it on.
Thank you for this excellent talk. It's absolutely like wonderful, succinct, on point, everything that I could have, we could have needed for in terms of treatment options. So thank you for that. It's
very welcome.
fascinating how quickly things are moving. Just, a few months ago, there's a new phosphonodiamidate 3 kinase delta inhibitor that's hit the market, which sort of emphasizes, at least for me, as an immunologist, like the importance of genetic testing, because even if therapeutics aren't available at the time, they may become available in the near future. So that's exciting.
Absolutely, absolutely. And I couldn't say it any better that, sometimes we have the targeted therapies, but we don't know that our patients could have potentially a defect that could benefit from those targeted therapy. And we get some pushback from getting genetic testing from some of the insurance companies, especially for adults. But now those cases highlight the importance of trying to get to the very specific diagnosis whenever possible, because as we move on and more targeted therapeutics are being developed, we could make a better impact on our patients' quality of life and long-term management.
As a patient, I would like to just really stress that concept of asking the patient, are they taking the treatment that they've been given for IVIG or sub-Q? They've talked a lot about with older patients, whether it's dementia or change in schedules or things like that, that many times they will be off their schedule, and that's why they're presenting with more problems. For the same thing with young kids who are in college and get busy and forget it and think it won't matter if I skip 1 or 2 or whatever. So that's really important to find out if a patient is actually taking their medicine as prescribed.
Absolutely. And we had some cases, they were referred to us from complications. And when we looked at everything, the one variable was those patients were off immunoglobulin, sometimes for several months because of change in jobs and insurance coverage. It's not the first thing that comes to mind. You would just assume that your patients are taking their medicine. And that's why I put this slide, because if you realize that they've been off their medication for a long time, then all those lymphadenopathy and concerns could have just been because they've been off their treatments.
Jude, could you do me a favor, please? Could you just very briefly touch on the most common side effects that somebody might see who is receiving IG therapy?
Absolutely. So if a patient is receiving IG therapy through the IV route, the most common side effects would be the systemic side effects. So patients could have a little bit of chills, body aches, headaches. Some people would feel tired. I would say the vast majority of the patients feel tired that day. A lot of my patients either do it at the end of their workday or do it on a weekend. And for those patients, we tell them to hydrate well, avoid caffeinated beverages. We sometimes give them pre-medication with Tylenol or ibuprofen. And if they get nausea, we give them nausea medicine and so on. For patients who are receiving the subcutaneous route, usually the dose is not the full dose. So you either give quarter of the dose every week or half of the dose twice a month. And for those patients, it's more of a local side effect because you're injecting a large volume under the skin. So the most common is you get a bulge, and it's oftentimes in the abdomen or the thighs area. It sometimes can be painful. If you don't have a lot of fat under the skin, there will be some resistance because the immunoglobulins actually are supposed to make a depot in the subcutaneous fat and distribute easily to the lymphatics. So we had some of our athletic patients who really are all muscle with no fats, they might feel some resistance and the infusion might be slower. We don't see a lot of bruising if the patients are doing it in the right way. And you see much less systemic effects, so less headache, less fatigue, less body aches when you infuse under the skin, because you're not giving the full dose and because you're not going through the blood vessel right away, but rather you're diffusing through the lymphatics.
Thank you.
Absolutely.
I had a quick question about the genetic studies, being that, you know, just in general, my son was diagnosed, but he had a whole exome and an immunology genetic study done about 5 years ago. Is there any way to think that the information, obviously the whole exome information is there, but having it rerun in a certain amount of time period, is that something that's commonly done or should be done?
It should be done. I would say commonly done is very variable depending on multiple factors. So not every genetic company offer free rerun on regular basis. And the reason is just that there is no enough system to deal with all those databases and rerun automatically. But if the case is not solved, usually the clinical immunologist would revisit every few years to kind of see if there are any genes that were not discovered 5 years ago in your specific case that are now reported. Or sometimes if there is a gene that was reported and it fits the phenotype, like the picture looks exactly the same, but that gene was just reported last year, you could go and specifically ask the genetics to pull up their file, because genetic testing is really like reading letters in a very large 7-volume book, and you are looking for misspells, and the computer is doing the looking, and the computer as well is filtering, because you know, the computer is supposed to go and read every single page of those large volumes, 100, 150, and that's what we call the depth. So reading one time is not good. So if they find the defect and it's only found 3 times or 4 times, they will filter it out as a artifact and not real. And they will filter some of the things that the computer would say, I've never heard of this before, so let me put it in another list of things that I don't know. But it is there. It's just you have to ask the question, is it there? And then you pull it back and you can say, was it read in all the chapters? Is it real or is it not real? So perhaps this is a very long question, answer to your question, but the answer is, at this time, I think we're not doing this routinely, but on targeted basis. So I think as clinical immunologists, we all have cases that are unsolved that we try to look at, just perhaps every follow-up in every several years, or more specifically, if we learn about a new defect that fits the phenotype, and we know that this was not included several years ago. There are panels which are kind of more comprehensive to deal with, that the companies sometimes send the clinical immunologist an update on certain variant that could have been reported as of unknown significance. And they say, we reclassified this variant, so now we think it's benign, so kind of don't worry about it anymore. Or we think it's problematic, so revisit that. And that's how I really hope in the future we'll have something more systematic. But I think this is something that we are all growing with right now, and hopefully we'll develop better ways of doing it for every single patient down the road.
Yeah, thank you. The company that I use, as you mentioned, for the most part, I think depending on the healthcare center and what the resources are of the healthcare center, you may get whole exome sequencing, which is probably sufficient depending on the case. Whole genome sequencing, if it's a healthcare center that really is more research focused and is able to get access to free whole exome, whole genome sequencing as part of their research component. And if not, within genetic panels are becoming much cheaper, and companies are able to even provide them for free sometimes, depending on agreements and things of that nature outside of the insurance coverage. So there's some areas of availability to get these panels that will test like 400, 600 of the most common genes that are affected in primary immunodeficiency. Now, that won't see everything that you would see in a whole exome sequencing or a whole genome sequencing, but it does take a look at the things that are most common. What is nice about those is that they are targeted to those genes, and the company does update. So I get updates all the time. So I'll have one patient, even though it's only been, let's say, 3 years, their genetic sequencing has been updated 3 times or 4 times because of new discoveries to the genes.
Thank you, everyone, for your questions and for your feedback. Can we move on to the case so we have enough time to walk through this?
Absolutely.
All right, thank you so much.
Absolutely. So this is a real case for this young man who presented. Now I follow him for several years, but at the time of the presentation that I thought most helpful is to zoom in at the when he turned 22-year-old. So he presented with chronic diarrhea, and he described that he had diarrhea for as long as he could remember, since childhood. But the reason that he presented at 22 is because within the last year before presentation, the diarrhea started to cause more problems. He describes the diarrhea as watery, non-bloody, and it can be 3 times per day and can be all the way up to 12 times per day. Through the years, this diarrhea will get worse, and that usually was attributed to infection. So over his lifetime, he developed 7 times C. difficile infection. He had a couple of Campylobacter infection, and he had a Salmonella infection as well. Through the years, his diarrhea caused him to have multiple hospitalization. He lost weight, and he even required to be on TPN because he was just not able to, absorb enough nutrients, that he was losing significant weight. So as a child, he recalls that he was born at full term and he thinks he was healthy. He had 1 episode of pneumonia in early school age year, required hospitalization. He did not recall that he had recurrent sinus infections or otitis media. When he was in college, he developed an episode of urinary frequency. And to make a long story short, he was tested. He was found to have CMV positive in the urine. They did a scope for his bladder, and it showed bladder wall thickening. So he was diagnosed with CMV cystitis. He never reported history of severe fungal infections. He did have, obviously, the CMV as a viral infection and had some warts. In addition to the severe diarrhea, he reported arthritis that started at the age of 22 as also, mostly in the small joints of the hand and wrist, but he also had pain in the knees and the shoulders and the hips. He saw multiple providers. He required steroid injection and also was given oral steroids at some time to kind of just ease the pain in. He worked as a school teacher and he had private insurance. So when we think about his physical health, the clear picture is that he had this long-term diarrhea that has affected his life, put him in the hospital multiple times, caused him to lose weight, required TPN, and the arthritis more recently started to affect his mobility. Down the road, when he was being investigated, he was diagnosed with hypothyroidism, and during some of those episodes with diarrhea, he actually became very hypotensive, and he was found that he had an adrenal insufficiency. So whenever he's stressed because of an infection or dehydration, he required steroids. Although also as well with the arthritis in the most recent year before presentation, he required oral steroids. So the provider thought maybe this have contributed to his adrenal insufficiency. From a psychosocial behavioral health, he appeared to be stable, and he, through the years, have sought medical attention from multiple tertiary care centers. He was seen at Mayo Clinic and finally was seen by the National Institute of Health, where he actually ended up getting his diagnosis. So I'll walk you through his immune evaluation because we're really going to be focusing more on the management here. That when he was investigated for his immunoglobulins, his IgA was 14, his IgM was undetectable, and his IgG is 158. If you don't look at those labs very frequently, I'll tell you that those are going to be highly red flagged in the chart. So you should not have undetectable IgM. The IgA is usually 70 or so is the upper limit. And your IgG, most of the labs in the US consider the normal range starting from 500 to 700, 800. So 150 is quite low. His absolute lymphocyte count is 410, and for adults, this number usually should be above 1,000, so this is also very low. His CD3, which reflects the total T cells, is 373, which is also very low because the vast majority of our lymphocytes in adults should be coming from T cells. His CD4 count is 158, and you can just relate to HIV, which we are all familiar more with the criteria. Anything less than 400 is very scary. And his CD8 count is 177, which is also low. And you may remember that your CD4 to CD8 ratio should be at least 1.2 to 1.7. So he is almost equal on his CD4 and CD8, which is not right. His CD19, he has only 2 B cells, which is not normal. I mean, our B cells usually about 10% of all our lymphocytes, so this is obviously very low. But as you see, he started from a very low lymphocyte count, so he's kind of low everywhere, which is expected. Because of his arthritis, they checked ANA, which was negative. Perhaps just a notation here, if you see somebody with very low immunoglobulins, anything serology-wise is not reliable anymore because this patient clearly has major defect in making antibodies. So having negative ANA, negative rheumatic factor, negative anything serology-wise is not surprising. He ended up having upper endoscopy as well as colonoscopy a couple of times. And the most recent one showed from EGD that he had gastric mucosal atrophy, which kind of translate to me that he had some kind of pernicious anemia and concern about vitamin B12. And he had a congested duodenal mucosa. And in the colon, he had focal cryptitis, which means that there is significant inflammation of immune cells in the crypts, and he had decreased plasma cells, which is an important point. Not every pathology lab will talk about plasma cells, but if they do and they say they are low, this should be a very important hint for us that those patients are not able to make antibodies, and it's usually considered the diagnostic criteria for patients with common variable immunodeficiency. He was CMV negative, which is an important question since I already mentioned to you that he had CMV cystitis. So this is when our mind as clinical immunologists not only look at the general term, but also kind of try to now personalize even the diagnostic plan for a patient with immunodeficiency. He had CT abdomen, which showed moderate splenomegaly and evidence of colitis. And to make a long story short, this patient had genetic testing that showed that he had a CTLA haploinsufficiency. It is a monogenic disease that presents like common variable immunodeficiency, CVID. It's inherited as autosomal dominant, and the presentation is very typical. It presents since sometimes childhood, but it's not unusual to present later in life. It is like CVID with recurrent infections, but patients also present with autoimmunity, a lot of gastric disease, a lot of lung disease, and a lot of arthritis. So based on this, and this patient was seen by multiple providers, but before the genetic testing, he was getting those therapeutics that I mentioned earlier, but perhaps without having that big picture. So when he was seen to have low immunoglobulins, he was started on immunoglobulin replacement therapy. And when he was found to have those findings of inflammation in the gut, you can call it inflammatory bowel disease-like, he was started on everolimus. Because he was having some infections and because of the low CD4 count as well, he was started on trimethoprim sulfamethoxazole, just kind of like what you normally do for your HIV patients for concern for PJP. Because of his CMV cystitis, he was started on valcyclovir. However, when he was diagnosed with CTLA haploinsufficiency, then abatacept became a targeted therapy that we know that is used successfully for patients with haploinsufficiency. And abatacept, for the rheumatologist on the call, they are very familiar with it. It's used for rheumatoid arthritis. The name for it is Orencia, and we know that this medicine does not start working right away, and that's why it's not surprising that you'll see your patient on multiple immune suppression. I mentioned earlier that this patient has received courses of steroids on and off. And of course, he receives as well treatment to replace the thyroid hormone because of his hypothyroidism. And at some point when he was in adrenal crisis, he received the appropriate treatment and eventually was able to come off the hydrocortisone for adrenal sufficiency. And I'm happy to take questions anytime, but I'm happy to go on as well. I know this is a very busy slide and could be overwhelming, but I thought if I put the management and the labs line by line, this could be helpful.
There was a comment. I'm not sure if it's a comment or a question. Anyway, he has inflammatory arthritis. ANA wouldn't help with this diagnosis. Sahar, if you want to elaborate on that, maybe we can address it.
Oh, just that. I mean, there's no reason to check an ANA if you're looking for inflammatory arthritis. Like, I guess I didn't understand why that was collected, and it wouldn't work in this patient. So I was just wanted to make it clear that the diagnosis of inflammatory arthritis is not dependent on ANA at all. So
Absolutely. Thank you, Zahar, for this. I guess a lot of our patients who land in our clinics already have ANA checked because somebody thought it could be any autoimmune disease, but absolutely, I try not to order ANA at all because of you and other people. Sahar, my colleagues in rheumatology, they don't like us when we do that. And it's because it's more confusing than helpful. But I put it there because I feel like a lot of time patients say, oh, if the patient had ANA negative, then the whole autoimmunity, which in a lot of people's mind encompasses autoinflammation as well, is ruled out. So perhaps one of the reasons I like to mention those is because we can all fall in the trap, but we definitely want to see imaging and kind of erosion and destruction that could be relevant. And we definitely refer our patients to rheumatology as well whenever we suspect that there is autoimmunity or autoinflammation in our patients with PI. Just checking the chat. Okay.
do you see correction in like which of this patient's symptoms, aside from the inflammatory arthritis, might be helped by the abatacept?
The GI disease is perhaps the most impacted organ, and oftentimes we use abatacept for the gut disease in those patients because it could be really impactful, very, very helpful in those patients. And among all the other options, perhaps the one that once you get them to a steady state and you get things under control, perhaps the least side effects compared to, for example, anti-TNF. So it's really now becoming more favorable for the GI disease. Now, this specific patient does not have interstitial lung disease, but CTLA-4 patients could have interstitial lung disease. Sometimes looks like granulomas, and we call it granulomatous lymphocytic interstitial lung disease. Basically, you see a lot of infiltrates and some nodules, and you need to biopsy this because it could be anything. But usually on a biopsy, it almost looks like sarcoid because there are non-caseating granulomas. But in the context of hypogammaglobulinemia rather than hypergammaglobulinemia, which you see in sarcoid, those patients do not respond to steroids at all, very different from sarcoid. So when you give them abatacept, sometimes abatacept is helpful for the lung. Those patients could also get liver disease, which this patient fortunately does not have, at least for the time being. And we don't have a lot of data whether abatacept is helpful for the liver, but I guess among all the organs that are being involved, I would say that GI is the most impacted organ in addition to the arthritis. But I would say even if this patient did not have any arthritis at all, abatacept would have been the way to go. Perhaps for that it will not work immediately, so we're going to have to bridge them through something. But the goal for some of those patients is to be on abatacept only without any other immune suppression if they can tolerate it.
That's great. Thank you.
Absolutely.
Another question that popped up was, I'm not sure exactly what it's getting at, but question, I think it's questioning, it says GI symptoms and everolimus. I think it's questioning the use of everolimus for the quote unquote inflammatory bowel disease is what my understanding is. Correct me if I'm wrong, Rita.
I think the everolimus was started before the genetic diagnosis, and the medications that's correct. Okay, so yes, you will see a wide variety of immune suppression medications used in patients with PI, and perhaps they are not going to be as targeted when you don't know the mutation. So multiple factors will play into account when you choose your immune suppression if you don't have a genetic target. So everolimus is not usually the first medication that I go to for GI disease, but this medication was tolerated by the patient, and it was perhaps the one medicine that put him into remission before the abatacept was used. And I think this is important as well because there are no guidelines when it comes to immune suppression in patients with PI. And honestly, a lot of time what we use is honestly dictated by insurance companies. So my preference would be A and then B and then C, but the insurance company will say they have to fail X, Y, and Z. And sometimes the only way to go around it is to try X, Y, and Z for a short period of time in order for you to get approval, because some of those medicines can be costly. I think another thing is that a lot of us prefer to use oral immune suppression if we can, because our patients are already on injectable medicine if possible, and if we think that they are able to absorb the medications appropriately. And contrary, if we don't think they can absorb, then we'll use injectable medicine. So I think multiple factors play in, and perhaps this is really a very, very important point on how do we start if we don't have a target. And I would say a lot of time we try to get biopsy. So for example, if I am looking at the lung and I ask the pathologist, can you do an extra staining to tell me whether what you're seeing is actually T cells versus B cells? So that means that they are going to do immunohistochemistry and stain for CD3, CD4, CD8, as well as CD19 and CD20. And if they tell me everything is T cells, then I may not use an agent that target the B cells like rituximab. But in granulomatous lymphocytic interstitial lung disease, which is a common lung complication, CVID, oftentimes you see infiltration with both B cells as well as T cells. So if I zoom in and know exactly that there are B cells as well as T cells, then the management plan will include rituximab to get rid of those B cells, as well as an agent to target the T cells like azithromycin or methotrexate or another agent. So those are kind of the points that are very important as a clinical immunologist to kind of even look beyond what the pathology, for example, is readily providing you and go into more details to now personalize the management plan for this specific patient, and so on. And Hajjar is saying,
I'm sorry, I'm going to interrupt again. We only have about 2 minutes left. So if you can address that last question or two and then do a wrap up, we can have everybody out on time.
Absolutely. So absolutely. I think that we kind of talked about his symptoms, the diarrhea, the joint pain, and the fatigue, and the comorbidities that were mentioned. So perhaps I can look at Dr. Lutfi Imran's question, because I think it kind of encompasses, once his gut is better controlled, was there any improvement in peripheral immunoglobulin levels? That is, did he actually did he have any aspect of protein losing enteropathy? That's a great question. So what Dr. Lutfi is alluding to, or Hajjar is alluding to, that some patients who are in immunoglobulins, when they have severe protein losing enteropathy, they lose some of their immunoglobulins in the gut. And we definitely see that if we can decrease the inflammation, that they can hold on their immunoglobulins a little bit better. And at this point, our patient is on stable dose of immunoglobulin, and he's at a therapeutic IgG level. He did have hiccups with his insurance, like many of our patients, so he dropped a little bit because of that, but we were able to get him back. There is another question. I have heard that using rituximab may actually help people with PI by eliminating the B cells. Is this true? Yes. So if the B cells are, they develop into plasma cells, they make the antibodies, but if those antibodies are autoreactive, meaning that they are attacking the body, then getting rid of those autoreactive B cells is helpful. And we use rituximab frequently when it's indicated to treat autoimmunity in patients with PI, and it's usually helpful.
Thank you so much. I'm going to go ahead and wonderful presentation. Going to go ahead and wrap this up, where we've reached 1 o'clock. So today we talked about different therapeutics and primary immunodeficiency, including prophylactic antibiotics, replacement with immunoglobulin replacement products, and curative treatments, which highlight the importance of genetics. And we had a wonderful case that specifically addressed that in the case of CTLA4 haploinsufficiency, highlighting the use of abatacept. So thank you all so much for joining us today.
Yes, thank you. Please watch your email. You'll be receiving one that has a link to the session evaluation and to our participant resources later. So if you are claiming any credit for this, you must complete the evaluation in its entirety. If you're not, we still appreciate your feedback as we continue to strive to improve this session and make these sessions and make them useful for you. And we will see you again on May 22nd. We'll be talking about the rare of the rare. So have a wonderful rest of your day, and we'll see you on May 22nd. Thank you, everyone.
Thank you.